morning. I think by now, hopefully, you all know who I am, and it feels good for once to be standing up here not presenting a complication. So today we're going to be talking about bariatric surgery, kind of the history of it, how we got to what we're doing today, and then some what we're doing in this present day. So just a few definitions. So we talk about obesity, but to really categorize it, a BMI of 25 to 30 is considered overweight, 30 to 35 is class 1, 35 to 40 is class 2, and then over 40 is class 3 obesity, or what we refer to as severe or extreme obesity. If we look at the trends in the United States over the past couple of decades, we can look at the distribution of the United States. And in 1990, you can see in teal is 0 to 10% of Americans are obese. The light green is 10 to 15. Yellow is 20 to 25. And then red is 30 to 35%. In 2012, this is what the map looks like. You can see there's a lot more red here, which is the 30 to 35%. And then in 2016, things are looking even worse, where now we're starting to see the purples come in, which are the 35% and over. And in red over here, North Carolina is where I'll be doing my fellowship next year. So as you can see, there's going to be a lot of business for me. This is a graph depicting kind of the overall trend of obesity in the United States. Overweight men have stayed relatively stable since the 60s. Similarly, overweight women, but obesity, there we go, in women has increased as it has in men, and then extreme obesity in men and women has also increased. And then women are slightly worse than men. And over time, it's getting worse and worse, as you can see. Interestingly, also, obesity is not the same across races. So both in children and in adults, Latinos and blacks are disproportionately more obese than their white and Asian counterparts. So what is the answer to the problem? We know that a healthy diet, exercise, government-funded programs that help us improve our infrastructure, making our communities safer for children to play outside, to get enough exercise, to improve access to healthy foods, are all imperative and invaluable factors that help fight this epidemic. But sometimes surgery is the answer. So this is an overview of kind of a timeline of where we've come from to where we are today. And it all sort of starts in the 1950s, and we're going to talk about the various procedures that have been thought of and modified over time. So 1954 is when the first true experiments in weight loss and malabsorptive surgery started. It started with Dr. Kremen and his counterpart, Dr. Linner. And I can only find in this older picture of him, he was a handsome young man in the Navy, so this is the photo that's most readily available on the internet. And interestingly, Dr. Linner started out as an internal medicine physician. Then he served in the Navy, and he decided at that point that he's never again going to be unprepared for any situation in life, and he did his residency in surgery. So what they did was they experimented in dogs, and this is a figure from their paper published in 1954, looking at the various experiments that they performed. So what they did was they experimented with removing the proximal 50% in the small intestine, the distal 50%, then proximal 70%, distal 70%, and then also with removal of the ileocecal valve and without. And what they found was that removing the distal 50% of the intestine results in severe fat malabsorption, also protein malabsorption, and significant weight loss. They also came to the conclusion that removing the proximal 50 to 70% doesn't affect dogs and their weight at all, which we know isn't true in humans. And then they also found that the ileocecal valve plays an important role in absorption. So this was the birth of what we know of currently as a jejunal ileal bypass. And over time, there were various modifications and versions of this, but classically, the proximal 35% of the jejunum is left, and it's anastomosed to the distal ileum 10 centimeters proximal to the ileocecal valve. And then you leave a long blind loop of small intestine. So literally you're leaving the patient with 45 centimeters of small bowel. There was also attempts in performing this operation in humans. After they published this paper in 1954 with their experiments in dogs, they performed the first small intestine bypass in a woman. It wasn't very successful. They tried it again in another patient with more extensive resection. They had to end up having to reverse it. But ultimately, after making a few modifications, they were able to have some patients in whom they were trying to do hernia repairs who are obese and failing repair of the hernias to lose some weight. But overall, this didn't work too well. In the 1960s, Dr. Howard Payne at USC created a jejunal-colonic shunt, which is sort of similar. However, he anastomosed the jejunum to the transverse colon, thereby bypassing part of the jejunum, the entire ileum, and the entire right colon. This didn't work very well either, and he ultimately ended up speaking out against the idea of this shunt and recommending to go back to the small intestinal bypasses. So these patients ended up with excellent weight loss results. However, they had a long list of complications, the least of which was diarrhea, but severe vitamin malabsorption and malnutrition, fat malabsorption, protein malabsorption that led to hepatic failure and death, and then severe bacterial overgrowth as well. So in the 1960s, another approach to bariatric surgery was sort of discovered. Dr. Edward Mason, who was at the University of Iowa, and his partner, Dr. Chikashi Ito, who was a visiting professor from Japan and happened to be working in his lab, were looking into gastrectomy and various types of operations that could be performed in patients with peptic ulcer disease. At the time, it was common that patients were receiving operations, and we know that classic ones is Billroth 1 and Billroth 2. And specifically in Billroth 2, where a patient who has a ulcer in the stomach, they would perform partial gastrectomies and then create a loop gastrojejunostomy. And Dr. Mason was looking for kind of novel approaches and thinking of different different gastrectomy operations that might help improve acid secretion in patients. So he thought of just transecting the stomach, but leaving the distal portion intact, unlike the Billroth 2, and then bringing up the loop gastrojejunostomy. So it didn't work very well. Patients still continued to have ulcer disease, and it didn't help to control acid secretion. However, they noted that these patients experienced weight loss and had a very difficult time keeping weight on. So this was kind of the beginnings of restrictive operations for gastric bypass. In the 1970s, Dr. Griffin created a gastric bypass with a Roux-en-Y reconstruction. So as opposed to bringing up a loop gastrojejunostomy, the jejunum was transected, and they created a gastrojejunostomy and a jejunojejunostomy. And this worked well because it helped to decrease the bile reflux that was seen with the gastrojejunostomies. It also helped decrease tension on that jejunal loop that was brought up, and added a malabsorptive component to the procedure. So not just creating a small gastric pouch, but also incorporating a portion of the small intestine that was bypassed. Over the years, there were a lot of modifications, experimenting with different gastric pouch sizes, with different lengths of the limbs. But overall, this is what we know of as the gastric bypass today. So leaving a small gastric pouch, a Roux limb, the biliary, pancreatic, or Y limb, and then a common channel. In the 1990s is when bariatric surgery was really revolutionized, and Dr. Whitgrove published the first series of 5 patients in whom he performed laparoscopic gastric bypass, and basically from this point on, it was shown that this was an effective and also very safe method of performing the gastric bypasses, and currently that's the standard of care. So we're going to go back. We jumped ahead to the 1990s, but prior to all the developments in the Roux-en-Y gastric bypass, there were several other operations that were being done for patients, some of which we still see today and others that have fallen out of favor. So the biliopancreatic diversion is an operation we don't see that often, especially not out in the community. But it was invented by a surgeon named Dr. Nicolas Copinaro, who was at the University of Genoa in Italy, which is located here on the coast. He spent his entire career, including medical school training, and then worked as a staff surgeon here, probably because this is what Genoa, Italy looks like. So the biliopancreatic diversion was an operation that was created with the hopes of improving the malabsorption that we saw with the small intestine bypasses, the severe protein and vitamin deficiencies, and the bacterial overgrowth that resulted from leaving that blind loop. So this is what the reconstructed anatomy looks like. Again, there's a gastrectomy with a small gastric pouch. There's an elementary limb that's about 250 to 350 centimeters, and then it's anastomosed 50 centimeters proximal to the ileocecal valve. So again, you see that it's a pretty short, a very short common channel for patients as compared to the Roux-en-Y, which we perform today. So this operation resulted in the best weight loss results. They had a high rate of curing diabetes, and it eliminated the problem of the blind loop. But patients still had severe complications that resulted from malabsorption, especially the vitamin and mineral deficiencies and the protein malabsorptions. In addition to that, they also had dumping syndrome that resulted from the creation of the gastrojejunostomy. So to kind of address several of these issues, there are two surgeons, Dr. Marceau and Dr. Hess, who in the 80s and the 90s experimented with the biliopancreatic diversion and added what we call a duodenal switch. It was to address the complications that they saw with the original operation, and partially because they noted that in patients who were coming back after restrictive operations for redo procedures, it was really hard to bring up a gastrojejunostomy. So they actually took the idea from a surgeon who's probably familiar to most of you, named Dr. Tom DeMeester, who did a lot of work in looking at reflux and GERD. And he invented an operation called duodenal switch to help with biliary reflux. So as opposed to the gastrojejunostomy, where the jejunum is brought up to a transected stomach, he transected the duodenum just distal to the pylorus and performed a duodenojejunostomy with Roux-en-Y reconstruction. So they combined that operation with the original one, and also added a sleeve gastrectomy for a restrictive portion of the procedure. So it resulted in a sleeve gastrectomy. The pylorus was preserved. A duodenoileostomy was created, and they also lengthened the common channel a little bit with the hopes of helping improve the problems with malabsorption. These patients did well overall. There was no dumping syndrome, as we saw with patients who had a gastrojejunostomy. There was less incidence of marginal ulcers. And lower incidence of malabsorption because of the common channel. But nonetheless, even though the patients still had very good weight loss results, they still had severe vitamin deficiencies. And this operation, though still performed in some centers that do bariatric surgery, they have to have very intensive follow-up and expertise. So it's not commonly performed the way other operations are. There are also the gastroplasties, which were kind of revised and worked on by multiple surgeons, including Dr. Mason. And there were multiple variations of this. And especially when surgical staplers became more common in the 1950s, this became more of a popular procedure. So some variations that were done were stapling kind of horizontally, leaving a little lumen for food to pass through, stapling vertically, and then passing through a little bougie and then tying off a little common lumen, or not a common lumen, but a lumen for food to pass through here. And then Dr. Mason was the one who developed the most commonly performed one, which is the vertical banded gastroplasty, which includes stapling the stomach vertically like this, leaving a tiny little pouch here, and then placing a little silastic band. The reason for that is because they noted that when the stomach was just stapled, this channel tended to stretch out with time as patients kind of ate through their gastroplasty. So they added this band to hopefully keep the lumen small. And then food would pass through, patients would feel full, and then pass on. So advantages: much more simple operation, easier for redo operations later if you wanted to revise to one of the other operations, no dumping syndrome, and no marginal ulcers. However, there was a lot of problems with the addition of this ring. Initially, they also experimented with adding polypropylene mesh instead of the silastic ring, and that had a lot of problems, including erosion into the stomach. And then also the staple line tended to break down. So then, kind of over the course, really from like the 70s, 80s, and onwards, what became the evolution of the vertical sleeve gastrectomy, and then early in the 2000s is when it really started to be used commonly as a standalone operation, including to today. So if you recall, the biliopancreatic diversion included a sleeve gastrectomy as part of the operation. And in the early 2000s, surgeons were experimenting in super obese patients where they basically created a two-stage operation where they first performed a sleeve gastrectomy, waited for the patients to lose weight, and then converted them to either a Roux-en-Y gastric bypass or a biliopancreatic diversion. So usually about 6 to 12 months later, patients would reach a weight loss plateau, and then they would go on to the second portion of the operation. But they found that patients were actually having really satisfactory weight loss results from the sleeve alone, and patients were so satisfied with these results that they didn't want to go on to the second portion of the operation. The very beginnings of the sleeve, actually, though, were started in the 1980s by Dr. Johnston in the UK, who created an operation called the Magenstrasse and Mill procedure, where literally this is the street of the stomach, where he stapled across vertically. So this was the little street where the food would pass in the stomach, and then this was the mill where the food was broken down in the antrum. The sleeve gastrectomy had durable weight loss results. There was no risk of marginal ulcers. There was no dumping syndrome. There was no risk of foreign body the way we saw with adding the mesh or the bands to the stomach with the gastroplasties that we saw. However, the disadvantage was in patients with reflux disease. Their disease often worsened, which we still see today. And then they had worse outcomes in terms of their improvement in diabetes. Also, kind of around this time, from the 70s onwards, was the creation of the gastric band. In the 70s, they experimented with polypropylene bands around the stomach. This is purely a restrictive procedure where you place a little band around the stomach, creating a small pouch with the hopes that patients would be able to eat less and therefore lose weight that way. In the 1980s, Dr. Kuzmak created an adjustable silicone band that was placed open, which was the beginnings of what we now know as the lap band. And then in 1993, Dr. Belachu, who's a surgeon trained in Ethiopia, created the laparoscopic adjusted gastric band that became popular for one time, but now is falling out of favor due to all the complications associated with it, including band slippage and band erosion. And patients had less durable weight loss results as well. There's also a lot of devices being created right now, namely endoscopic devices that are literally like balloons placed endoscopically that are then inflated to hopefully take up space inside the stomach to help patients eat less and lose weight. But there haven't been large trials showing the efficacies of these, and currently they're not the most widely recommended procedures for effective weight loss results. So where are we today? We've gone through an overview from the 1950s to the 2000s. And we'll kind of talk about what we know now in bariatric surgery and what's currently being done. So we know that bariatric surgery is effective. There's been a lot of trials that have come out now since the mid-2000s looking at how patients are doing and the overall results. So this is a paper just published in 2018 comparing intense lifestyle modifications, which include supervised programs in diet and exercise, and comparing them to patients who receive bariatric surgery and the effects on weight loss and their metabolic syndrome. So in this study, this is an observational follow-up following a randomized controlled study looking at the 5-year outcomes. It was in multiple centers in the US and Taiwan, and they had 120 patients, half of whom were randomized to lifestyle modifications and half to lifestyle modifications with a gastric bypass. And as you can see here, across the board in all categories, patients who had the gastric bypass did much better than their counterparts who only had medical intervention. So hemoglobin A1Cs were lower, blood pressures were lower, cholesterol and weight loss were all lower, and the effect was seen over a course of 5 years. Another paper also recently published in Norway looked at their experience with 1,800 patients, so a bigger group. Again, half stratified to medical management, half to bariatric surgery, and the majority of these patients received the gastric bypass, and they followed them over 6.5 years. And again, they saw much better rates of remission for diabetes, lower rates for new onset diabetes in the surgical group, which is here in orange, and then similar results for hypertension, much better remission rates and much lower new onset rates in patients who had surgery. Interestingly, they did see that opioid use was higher in terms of new onset for patients who received surgery, so that's something that's important to counsel patients on. And then also new onset of depression was more common in the surgical group. So it's yet to be determined, why that is. This is a follow-up for up to 7 years, but it's something important to note. These are the current operations that are being performed today. Most commonly, the lap band, as we talked about, initially became very popular, but it's fallen out of favor due to the high complication rate of band slippage, band erosion, and less effective weight loss results. So currently, the sleeve and the gastric bypass are the two most common weight loss operations. This is a graph from data published up to 2011, so it's not quite up to date, but it's showing the trend in bariatric surgery. So we can see that there was a huge rise in the early 2000s in patients receiving bariatric surgery overall. The gastric bypass was the operation most commonly being performed, and the sleeves were increasing, and currently it's much higher for the sleeves, actually. The lap band became very popular for a little bit of time, but now much less common because of the complications. And then the biliopancreatic diversion still being performed at a steady, low rate. So again, recently, just in 2018, 2 large trials were published comparing the gastric bypass to the sleeve. And this is a study out of Finland looking at their data in 240 patients, half of whom were randomized to sleeve and half were randomized to the gastric bypass, followed over 5 years. This is a brief summary of the patient characteristics. 80% of them were women, which is what's commonly seen. BMI 45 and 50% had diabetes. And they showed pretty similar weight loss results in terms of excess weight loss and BMI over 5 years, showing that the sleeve and the gastric bypass had no statistical significance in the difference in weight loss between the two operations. There was a slightly improved rate of weight loss in patients who had diabetes, but again, not statistically significant between sleeve and gastric bypass. And then one more trial that recently came out in Switzerland, looking at 205 patients, again comparing the sleeve and the gastric bypass, showing similar results. No significant difference in weight loss between the two, no significant difference in remission of diabetes, but importantly, they did show that patients who had received sleeves had worse outcomes in terms of reflux. So had worsening reflux after the sleeve, and more frequently, patients who received the bypass had remission of their reflux. Overall, the sleeve pass trial also showed that bariatric surgery is safe, which is always important to think about when counseling patients, because if you're looking at medical management versus bariatric surgery, these are the questions that patients are going to ask. And of course, if a patient's undergoing medical management, not surgery, then the risk of complications is zero because you're not exposing them to those. But looking at the overall morbidity, 19% with sleeve, 26% with bypass, and 0% mortality over 5 years. They broke up their complications by early, minor, and early late, so within 30 days. Sorry, I'm trying to say early, minor, and early major. And looking at the major complications, we see there was 5% rate of major complications with the sleeve, things that include bowel perforations, and then with the gastric bypass, which includes torsion, basically like volvulus. And then late complications, again, looking at the major ones, which are the most important ones, there was a higher rate of internal hernia with the gastric bypass, as we would expect, about 14% over 5 years. And then also looking at incisional hernias and gastric reflux. So one last topic that I wanted to address is pediatric obesity. We obviously know that it's a major problem in adults, but what about in children? So currently, 16% of children ages 2 to 19 are obese in the United States. And 9% of children ages 2 to 5 are obese. And we know that obese children become obese adults. So this is a problem that we need to look at starting early on. Some other interesting statistics that I found was U.S. high school students are physically active for at least 60 minutes per day, 27% of them, which to me was shocking. 42% of students in the U.S. and high school spend 3 or more hours on the computer outside of classroom time. And then 15 million children in the U.S. live in food insecure households, so households that don't have consistent, adequate access to healthy, nutritious food. We also know that children who are obese are at increased risk for cardiovascular disease. So there have been multiple trials showing that the higher a child's BMI, the more likely they are to have associated comorbidities, such as elevated blood pressure and impaired fasting glucose levels that increase the risk of cardiovascular disease. There have been several centers who are doing bariatric surgery in pediatric patients. There haven't been a lot of good trials just because it's not that common in children, but this is a study out of France published in 2015 where they looked at placing lap bands in patients and the overall efficacy. So they had a group of 16 patients that they followed for 2 years in whom they performed the laparoscopic adjustable gastric band. The children were ages 16 to 19, and overall it worked okay. They had a 13% weight loss over 1 month and a 40% weight loss, excess body weight loss, over 6 to 12 months. The median BMI decreased from 40 to 36%, and they had associated improvements in comorbidities. It's a small sample size, of course, but they did see good results in these patients. The interesting thing to note here, I think, and it speaks to why a multidisciplinary approach is imperative to weight loss in adults, of course, but especially in children. So looking at kind of the characteristics of the kids, 12 out of 16 of them had very difficult home environments, including parental suicide, substance abuse, and divorce. And the mean age of onset of weight gain was 4.9 years. And then all the children had significant stressors in their life during the time of their weight gain onset. And then this was all of the complications listed, the most common one being food intolerance with the band, and also continued food intolerance after the band was deflated, which we know to be a complication of the band. So in conclusion, bariatric surgery was founded on the principles of general surgery and gastric physiology. We know that it's an effective mode of weight loss. And we're going to start seeing more and more of these patients in our practices as we go on. And we're probably going to start seeing more and more children who have undergone bariatric surgery as well, which is going to apply to all of us regardless of what specialty we end up picking. So a few last words while I have you as a captive audience. I've been here for 9 years now, and I can't believe that it's coming to an end. So for those of you med students who think that this time doesn't come quickly, it comes much faster than you think. And I want to say a special thank you to the faculty here who invested their time and energy into training me to hopefully be a good surgeon. I specifically want, Dr. Galante's not here, so I can't embarrass him. But when I was a medical student, my 4th year, I met with him, and I kind of talked to him about my concerns about going into surgery and thinking maybe this isn't, maybe I'm not the personality type, and he really kind of encouraged me, and I haven't regretted that decision since. So I want to say a special thank you to him and also our associate program directors. A special thank you to Dr. Ali, he was over here, who also really provided a lot of mentorship and guidance in helping me find the right fellowship and match into what hopefully will be a good fit for me. Dr. Trotman, who's been a little bit of a life mentor, but also a true role model in what it means to be a good surgeon, both in the operating room, but also an excellent bedside manner and how we take excellent care of our patients and helping them feel like we really care about them as people overall. And of course, Dr. Farmer, who serves as an excellent role model and an excellent leader, but also never forgets the little people and is kind of constantly surrounded by a gaggle of medical students and residents. And then lastly, to my residency family, without whom residency probably would have been impossible. And if you guys are wondering, this is Katie Iverson, our intern year when she came in as a 911 trauma after having penetrating stab wound to the chest. And that's it.
We'll open it up for questions.
Hopefully I didn't put too many of you to sleep.
Dr. Lee still here? We'll start with Dr. Trotman.
Wonderful presentation, and I think you gave such a thorough history, and it's interesting to see where we are today, and I think we're going to be a fantastic bariatric surgeon.
Thank you.
We look forward to your success. You showed that the depression rate goes up or is higher in the surgical group, and I know that there is some preoperative counseling to a degree with the psychologist on the team, but how do you think we can work with some of these people? Because I do know some of them expect a completely different life once they're thin, and when they are not as thin as they think they should be. I mean, do you think that's a big part of it, their false expectations, or how would you address that and improve that result you shared?
Yeah, I think it's hard to know really, and they don't really tease it out in these studies, but yes, patients always receive preoperative psychological counseling, but I think it's important to kind of continue that, and it would be interesting to see how often patients follow up with a psychiatrist over time after their surgery, like 5-6 years out. And I think part of it's also setting expectations, because I think a lot of patients have bariatric surgery to improve how they look, but emphasizing that it's actually improving their health and their lifestyle and their diabetes control, et cetera, kind of emphasizing that as well. Yeah.
Dr. Lee.
So obviously very proud of what you've accomplished, and wish you the best. I'm sorry I can't say the word of the place you're going because that's just against me. But I obviously love your residency program, and your program director is a friend of mine. I know you, which is great, and you'll be trained. This is all about basketball. It's really quite far along the way, and maybe not far enough. But no one ever says to a patient, you have blank cancer, right? It's staged, it's probably, you've got a biopsy, there's, molecular thing. So therapy is tailored to a large extent, at least for some cancers, to that individual's risk of morbidity, mortality, and how they respond. Obesity has been, you come in and you're obese, right? I mean, no, we don't really differentiate at all. And so I'd like to kind of hear your thoughts about that. Hopefully I'll send you off with the idea that you and your generation, so that will be the next thing for you, is to further differentiate a disease that we really are very, very, very early in identifying different patients. So what are your thoughts? How are you going to go about in your future trying to, I guess, be more specific about what obesity is in an individual patient?
Mm-hmm. Yeah, I think it's interesting because especially we see that not all obese patients are the same. Some of them have worse metabolic syndromes, worse glucose intolerance, worse hypertension than others. And so people have been looking into it, like you have been in the microbiome, but also looking at different hormone levels in patients, ghrelin levels, and other satiety hormones. And so maybe with time, we'll be able to kind of do like a genome microarray and say, you're the type of patient who's obese, but also you're like horribly diabetic and insulin resistant, and you're the type of patient who's obese, but maybe has a better metabolic profile, and then perhaps stratify them. Maybe based on the type of operation they get, maybe how intensive we are in terms of their, does an endocrinologist follow them? Does, a psychiatrist follow them more closely? But we are definitely far away from that. Yeah. Dr. Z?
My last slide is a little different direction. So as a surgeon who operates the bariatric surgery, there's obviously huge societal and environmental component. As a surgeon who takes care of these patients, how do you fit in fixing that problem, which leads to people who eventually regain weight, who aren't successful, and the overall society problem. So somebody who operates on these patients, how do you fit into the society problem that's developed?
Sorry, in terms of society problem of patients who are obese or who have received bariatric surgery and failed?
Well, it's both. It's the same thing. I mean,
Yeah.
People are obese because both their microenvironment and society.
Yeah. And I think, and absolutely, I mean, this is not a presentation on bariatric surgery as the answer to obesity, because I agree with you. It's about making a society in which obesity is not normal, in which we address it and kind of invest in, the infrastructure in our cities, investing in kind of access to healthy foods, roads, bike lanes, et cetera, to hopefully try to actually prevent it in the younger populations, and then kind of encourage adults to live healthier lifestyles. So I think, it's just a very small component, and I think everything else is actually probably the most important part of it, really, if that answers your question.
He shrugged. It didn't answer your question. His question. How are you going to make a difference?
I'm going to perform these operations.
Further questions or comments? Thank you, John.
Thank you.